Welcome to the World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global healthcare. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high-stakes, critical, and emergency situations. WICCEM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary, cardiovascular, and neurology specialties. From advanced training in emerging techniques to hands-on experiences in critical care, life support, and emergency medicine, our programs are designed to equip you with the skills needed to thrive in demanding environments. Our expert faculty, who offer lectures, mentorship, and innovative insights through annual conferences and webinars. With our online learning platform, you can access courses, workshops, and a rich library of resources from anywhere in the world, making education accessible no matter your location. WICCEM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare.
Hello, everyone, and welcome to our first webinar of the Pediatric Cardiology Fellowship. And I will have just a very brief introduction about the fellowship. Hello, everyone, and welcome to our Pediatric Cardiology Fellowship webinar. This is the first educational activities we are conducting for pediatric cardiology field, and we are starting today with the Pediatric Cardiology Diagnostics. We have great speakers and panelists today. We have Dr. Qasim Mahdi from University of Southwestern, Dallas, Texas, Professor Hala Agha, Professor of Pediatric Cardiology from Cairo University. Dr. Amr Hosseini. I'm the President of the World Institute of Critical Care and Emergency Medicine. We have also Professor Amira Esmat, a Professor of Pediatric Cardiology in Cairo University, and Dr. Omar Al-Gunaid, who is a pediatric cardiologist in Saudi Arabia. So I'm just giving you some heads up about our WICCEM Pediatric Cardiology Fellowship that we are going to start soon. It's structured as 3 modules, 16 weeks each. So it's wholly online, 1-year program. And it's not only based on lectures, but also you will have a lot of journal clubs, MCQs, clinical case discussion, and clinical scenarios. We know that our retention rate is limited when it comes to just unilateral or one-way educational activities. So we are trying to limit the educational activities through lecturing and reading, but we are going to have more demonstration, audiovisuals, discussion, and our aim is to let you apply this clinical knowledge in your clinical practice and also to help you to teach. So we gathered very good expertise from all over the world, from United States of America, Canada, Saudi Arabia, Egypt, and more. And again, it's 1 year, a wholly online program, and it's a dialogue, not a monologue, and it's a real education, not only based on live webinar or recorded lectures. And you will have the freedom to navigate throughout the whole year and read and listen to the lectures and do your assignments, but you need to submit your tasks every week in timely manner. So all of our fellows' activities and assignments and tasks are monitored through a very smart platform, and there will be a weekly quantitative and qualitative evaluation, not only based on their scores, but also on their engagement and their performance. So one of the major aims of our fellowship is to recognize the limitations and the weaknesses that our fellows have and to improve their weaknesses and to lead them to master the field of pediatric cardiology. So the first module, which will be teach over 4 months, will be focusing on applied cardiology, anatomy, physiology, pharmacology, cardiomyopathy, myocarditis, rheumatic heart disease, and infective endocarditis, and the common pediatric cardiology problem. And more emphasis will be given on diagnostics such as ECG, echocardiography, chest X-ray, cardiac CT, cardiac MRI, and diagnostic cardiac cath. The second mini module that will be also teach over another 4 months will be focusing on cyanotic and acyanotic heart disease and neonatal cardiology. The module 3 is advanced topic involved electrophysiology, pacemakers, different kind of arrhythmia, critical care cardiology, and perioperative pediatric cardiology management, and also will be focusing on applying AI and the simulator in pediatric cardiology and different new techniques of the mechanical circulatory support and also the heart transplants. So upon finishing this 1 year online fellowship, our graduates will receive a certificate from the American Association of Continuing Medical Education, a graduation certificate with 96 credit hours, and they are going to be trained to be mentors, and also they can join our panel of tutor in the future. So we are trying to improve our pediatric cardiology patients' outcome and also the standard of care of our physician, because knowledge itself has no value until we put it in practice. And the great aim of education is not the knowledge itself, but the action. With that, I'm going to let Dr. Qasim Mahdi to give the first presentation. It will be followed by introduction from Dr. Amira Asmat, who's going to introduce Dr. Hala Agha to give a very fantastic echocardiography in NICU presentation. Then Dr. Amira and Dr. Omar Al-Gunid are going to moderate the session and trying to help answering the question with Dr. Hala and Dr. Qasim. So great speaker, great panelist. I'm very sure that you will enjoy this event tonight. So we'll start with the first presentation, the ECG by Dr. Qasim Mahdi from University of Southwestern Dallas, Texas.
Good morning, everyone. My name is Mohammed Qasim Mehdi, and I've been tasked to go over the basics of an electrocardiogram in 20 minutes. So without further ado, let's get right into it. And my goal for this talk is that by the end of it, all of us are going to be able to analyze this EKG in a stepwise logical approach. And so before we get into the specifics of an EKG, I wanted to go over the basics. And we know that the pacemaker of the heart is in the sinoatrial node, which is located at the junction of the SVC and the right atrium. Once the impulse is generated, it spreads into the left atrium and through the AV node down the His-Purkinje system and then travels to the ventricular myocardium, where it causes ventricular depolarization, which results in ventricular contractions. And so the EKG is comprised of different waveforms. The P wave represents atrial depolarization, the PR interval represents the delay of the AV nodal level, and then the QRS represents ventricular depolarization, and the T wave is representative of the ventricular repolarization. And so an EKG is indicative of the electrical activity of the heart. But one can argue that it also conveys some structural information as well. And how it does that can be explained by an analogy that my mentor gives his patient. And that is, if you were to tear down the walls of this room, just by looking at the arrangement of the wires, you could tell how big the room is, or was actually, and where the walls were. And so just by looking at an EKG, you're able to derive some information regarding the structure of the heart. And before we move on, I wanted us to be able to distinguish between intervals and segments. Generally, intervals are longer than segments. And what I mean by that is if you look at the PR interval and PR segment specifically, the PR interval actually starts at the initiation of the P wave and ends at the start of the Q wave. The PR segment, however, starts at the end of the P wave and extends all the way to the initiation of the Q wave. The same applies for the ST interval versus the ST segment. The ST interval starts at the initiation of the J point and ends at the ending of the T wave, whereas the ST segment extends from the J point till the initiation of the T wave. And so what does each small box on the x-axis and each small box on the y-axis represent? The x-axis represents time and the y-axis represents electrical activity. Each ECG is printed on this gridded paper, which has a speed of 25 millimeters per second. And so each small box is 1 millimeter and represents 0.04 seconds on the x-axis. And thus a large box, which is 5 small boxes, represents 0.2 seconds. On the flip side, the y-axis has these small boxes, and each small box on the normal standard EKG represents 0.1 millivolts. And so it takes 10 boxes on the y-axis to get to 1 millivolt of electrical activity. And before we start to evaluate an EKG, it is important to note the patient's age, as values and normative values can change as the patient grows older. We need to know the standardization, and that is marked at the beginning of an EKG with a calibration signal that produces a rectangle, and that rectangle is 2 big boxes tall and 5 small boxes wide. Occasionally, in cases of ventricular hypertrophy, for example, when the voltages are high, the gain can be adjusted to half standardization, and in this setting, 1 millivolt is 1 big box, or 5 millimeters on the y-axis. And therefore, the voltage complex amplitude has to be multiplied by 2 to get the true electrical amplitude of that particular chamber. The paper speed is also very important. The standard is 25 millimeters per second. And so the faster the paper speed, the slower the heart rate will appear, and vice versa. This is the basic approach to analyzing an EKG. You first calculate the heart rate, you go on to assessing the rhythm, then you go to determine the axis, and then you calculate durations and intervals. And we're going to do that now. The heart rate is quite simple. You start by dividing the 300 by the number of large squares between 2 R's. And so if there's 1 square between 2 R's, that's going to correspond to a heart rate of 300. If there's 2 squares between 2 R's, then that corresponds to 300 divided by 2, 150. 100 divided by 300 divided by 3 is 100, so 3 boxes is going to correspond to a heart rate of 300. So if there's 4 boxes, 75, 60 if there's 5, 50 if there's 6, and so on and so forth. Typically, we do use lead 2 for this assessment. Moving on to the rhythm. There are 4 levels of conduction and potential pacemakers in the heart. from fastest to slowest, we have the sinoatrial node, we have the atria, then we go on to the AV node, and going to the ventricles last. If the rhythm is not sinus, we have to determine the origin of the pacemaker and where the impulse is being generated from. And so a sinus rhythm requires three criteria. There should be one P wave preceding each QRS complex. All P waves should be uniform in shape and morphology, and there should be normal P wave axis. And what I mean by that is that it lies in the left lower quadrant, and that means that it's upright in both lead 1 and AVF, unless there's dextrocardia. And I'm going to explain this concept in further detail in the next slide. But before we move on, I wanted to make sure that we understand that the RR interval in a normal sinus rhythm does not have to be uniform, because with changes in breathing, you can have changes in parasympathetic drive, which can lead to changes in the heart rate as well. And so you may have seen different iterations of this diagram where you have the heart and these different leads. Essentially, what it means is that lead 1 represents an electrical impulse traveling from the right to the left. Lead 2 represents an electrical impulse traveling from the right upper quadrant to the left lower quadrant. AVF represents an electrical impulse traveling inferiorly, and lead 3 represents an electrical impulse traveling from the left upper quadrant to the right lower quadrant. And so using our imagination a little bit, we have the sinoatrial node here generating an impulse which travels to the AV node down the His-Purkinje system and then depolarizes the ventricles. And so because the impulse is traveling from the right to the left, it's going to be positive in lead 1. Because it is traveling from the right upper quadrant to the left lower quadrant, it is going to be positive in lead 2. And because it is traveling inferiorly, it's going to be positive in AVF. Hence, the P wave axis is going to lie within the left lower quadrant, and that is what I was referring to 0 to 90 in the previous slide. I hope that makes sense. So we have an EKG here of a patient. As we can see, all three criteria of a normal sinus rhythm are being met. There is a P wave before every QRS. Every QRS is being preceded by a P wave. There's uniform morphology across the rhythm strip. And then the P wave axis is positive in lead 1 and positive in AVF. Hence putting the P wave axis in the left lower quadrant. And so we can safely say that this patient has normal sinus rhythm. This is another example of a patient in sinus rhythm where you have all three criteria being met. There's a P wave before QRS, QRS after every P wave. The P wave morphology is uniform, and the P wave is positive in lead 1 and AVF. However, you can see here that the RR interval is quite inconsistent, and so you have a diagnosis of sinus arrhythmia. An atrial rhythm is normally characterized by having a narrow QRS complex, which is preceded by P waves that do not fulfill one or more of the normal sinus rhythm criteria, which I mentioned earlier. And so if the P wave morphology changes throughout the rhythm strip, this may indicate something that is called a wandering pacemaker, which can be normal in some patients. And so here we see that there's a P wave before every QRS. The P wave morphology is quite uniform as well. However, the P wave is inverted in lead 1 and it is inverted in AVF. And so it's probably going to be an impulse which is being generated from the left lower atrium. So you have a diagnosis of a left lower atrial rhythm. An AV nodal or a junctional rhythm is characterized by narrow QRS complexes that are not preceded by P waves. And an inverted P wave can be seen following the QRS due to retrograde conduction through the AV node. And so this is an EKG where you have narrow QRS complexes which are not being preceded by P waves. And if you look at lead 2 here, you see that there's a P wave which is buried right after the QRS, and that is indicative of a retrograde P wave retrograde conduction, hence junctional rhythm. A ventricular rhythm, to keep things simple for the purpose of this lecture, is characterized by wide QRS complexes that are not preceded by P waves. And in this example, we see that the QRS complexes are quite wide. Interestingly, there are some P waves here at the start of the strip, but as we continue to follow along, the P waves disappear. So this patient likely has a ventricular rhythm. The cardiac axis is another thing that we have to take a look at. It's determined by the cardiac mass or the ventricular mass. So you have to look at the QRS axis. So if the QRS is positive in lead 1, positive in AVF, then that means there is a normal QRS axis. If it's negative in 1, positive in AVF, then that means that the cardiac mass is concentrated on the right side. There's right axis deviation. If it's positive in lead 1, negative in AVF, then that is indicative of left axis deviation, and there's extreme axis deviation if it's negative in both lead 1 and AVF. Just going over chamber enlargement criteria, a P wave, as we talked about earlier, represents atrial depolarization. It's usually 2.5 millimeters wide or 0.08 seconds, and it's 2.5 millimeters high. A tall P wave means that there's right atrial enlargement, and a wide P wave is indicative of left atrial enlargement. And if there's both criteria, then you have biatrial enlargement. How I like to remember this concept is that the sinus node is located in the right atrium. And so if your right atrial chamber size is enlarged, the impulse or the electrical activity is going to be higher. So your amplitude is going to be higher as well. If you have, on the other hand, left atrial enlargement, then the impulse is going to have to travel over a longer distance. And so that is going to result in a wider P wave. The PR interval represents a delay in conduction in the AV node and conduction through the His-Purkinje system. It's typically less than 0.2 seconds at any age, but again, there are age normative values. The QRS, on the other hand, represents ventricular depolarization, and it ranges between 0.07 to 0.12 seconds. Again, this range changes with age as well. Importantly, there are three main differentials for a patient with a wide QRS complex, and that those include ventricular contractions, a bundle branch block, and more importantly, a concept that is frequently tested on boards, pre-excitation or WPW. And what that is that there is an accessory pathway which results in a delta wave, and that results in a wide QRS complex. The QT interval is measured from the beginning of the Q wave to the end of the T wave, and it represents both ventricular depolarization and ventricular repolarization. It is calculated by the Bazet's formula as we want to correct the QT for the heart rate. And so that is calculated by dividing the QT interval in seconds by the square root of the RR interval in seconds. An important thing to note is that we often calculate the JTC by subtracting the QRS duration from the QTC, and that is often done in patients with a wide QRS complex. T waves are usually asymmetric, have low amplitude, and it's best assessed in the lateral precordial lead, so V4 to V6. The amplitude does vary with age. And important to note is that the T wave in V1 it will usually have a positive deflection in the newborn. It becomes negative during the first week of life, and it stays negative till early adolescence, where it may become positive. And low amplitude is defined by being less than 2 millimeters, and high voltage is defined by being more than 7 millimeters in a limb lead or being more than 10 millimeters in a precordial lead. And abnormal T waves are indicative of either ventricular hypertrophy with strain, myocarditis, pericarditis, myocardial ischemia, and then bundle branch blocks as well. These are the criteria for right ventricular hypertrophy. So you have the voltage criteria, which is tall R waves in V1 and a deep S wave in V6. How those are defined is by the amplitude being more than the 95th percentile for age. You need to have a right axis deviation. There's an RSR prime in V1 with a tall R prime, a QR pattern in V1, and an upright T wave in V1 greater than 1 week of age. And so this is an EKG of a patient with right ventricular hypertrophy. Important note is that this is standard EKG, as we see here. There is a negative QRS in lead 1. There's a positive QRS in AVF. The QRSs are facing right towards each other, so there's right axis deviation. There is a tall R wave in V1. There's a deep S wave in V6. So you have voltage criteria, and then you have a QR prime as well, pattern as well. And so you have the diagnosis of right ventricular hypertrophy. Left ventricular hypertrophy is the exact opposite of right ventricular hypertrophy. I will say that the criteria are a little controversial, but you have the voltage criteria, which is a tall R wave in V6, deep S wave in V1. You'll have left axis deviation and a strain pattern in the left precordial leads, which means that there's going to be inverted T waves in V5 and V6. And so again, this EKG has a half standard as indicated by this box here. You have a tall R wave in V6, you have a deep S wave in V1, and so this patient has voltage criteria for left ventricular hypertrophy. The ST segment should be isoelectric to the PR interval. Changes can be benign or pathologic. How we define pathologic is if there is ST segment elevation or depression by more than 1 millimeter in the limb leads or by more than 2 millimeters in the precordial leads. In contrast to adult patients, pediatric patients rarely have ST segment changes because of myocardial infarction. Causes of ST segment changes include pericarditis, myocarditis, sometimes channelopathies, for example, Brugada syndrome can cause ST segment changes, and then, of course, from congenital cornea anomalies or postoperative changes in patients with congenital heart disease. There is this entity called benign early repolarization changes, especially in young athletes, where you have concave or upward curving ST segments, which is usually a benign finding in this population. This is a distribution of EKG leads by the perfusion pattern. And so 2, 3 AVF are called inferior leads, and they are supplied by the RCA. V1 and V2 are called anteroceptal leads, and they're perfused by the proximal LAD. V3, V4 are anteroapical leads, which are perfused by the distal LAD. Anterolateral leads are V5 and V6, which are supplied by the circumflex artery. And 1 and AVL are lateral leads, which are also supplied by the circumflex artery as well. And so this patient has ST segment changes in 2, 3, and AVF. So inferior leads are affected, and this patient also has ST segment changes in V4, V5, V6. So this patient has EKG changes, ST segment changes in the lateral leads as well. So the RCA and the circumflex are likely to be affected in this patient. And so going back to where it all started, I will tell you that this is a 13-year-old patient who came in with chest pain. So this is a full standard EKG running at 25 millimeters per second. The heart rate is 300 divided by 2.5, so about 120. There is a P wave before every QRS. There is uniform P wave morphology, and the P wave is upright in 1 and AVF, so sinus rhythm, actually sinus tachycardia because it's a 13-year-old with a heart rate of 120. So sinus tachycardia, the QRS is negative in 1, positive in AVF. The QRS complexes are facing right towards each other, so right axis deviation. The PR interval, let's see, so it's about 3 small boxes here. So 3 times 0.04 is 0.12. The QRS duration is about 1.5 small boxes, so about 60 milliseconds. QT, let's see. Okay, so it's about, the QT is about 7 small boxes, so 280. The RR is, let's see, it's about 16 boxes, so it's going to be about 0.04 times 16, 640 milliseconds. 280 divided by square root of 640 is 440 milliseconds. I'm sure you all see these ST segment changes, diffuse ST segment changes in all leads. And so with this patient's history and EKG showing sinus tachycardia, right axis deviation, and diffuse ST segment changes, this patient likely has acute pericarditis. These are some of the resources that I've used during residency and fellowship. Feel free to take a screenshot. That's all I have. Thank you so much for your time and attention.
Very nice. Thank you so much, Dr. Qasim. And I will let Dr. Amira, Professor Amira, a professor of pediatric cardiology from Cairo University, to introduce Professor Hala Agha.
Thank you very much, Dr. Qasim. It was very informative, and it gives just the hint for what we do have during our arrhythmia and ECG sessions in our fellowship. Now, I just want to thank you all for taking the time to join us. It's time to introduce our speaker today. She's a highly respected authority in the field of pediatric cardiology, added a lot to a lot of trainee and a lot of even full professors now like me in teaching. I've learned a lot from Professor Dr. Hala Agha. It's my great pleasure to introduce her. She is one of the eminent pediatric cardiology professors and consultants in Egypt and in the Middle East. It's time for her to come to share her valuable insight and expertise in role of echocardiography in NICU.
Good evening. Very nice presentation. Thank you, Amira, for this nice introduction. It is my pleasure to share with you my presentation. Thank you, Professor Dr. Amr Al-Husseini, to give me this opportunity. I will focus in my presentation of the role of echo in NICU. This is my disclosure. I have no financial interest. During my presentation, I will try to focus on the indication of echocardiography in NICU and show some practical algorithm for PDA in preterm and pulmonary hypertension of newborn. Why echo is very important in NICU? It is non-invasive bedside tool to assess the cardiac structure and hemodynamic, and bridges between our clinical evaluation, we are a clinician, and when you are using advanced hemodynamic monitoring, and guide and management of PDA, especially in preterm, PPHN, hypotension, and shock. We have a different vendor of portable echo machine and a small footprint of the probe where we can fit over the precordium of our tiny baby. The main problem when we are dealing with our neonate is the change of the hemodynamic. Variable cardiac output, unstable cardiac output, shifts of physiological status, and how to diagnose properly this baby. Is it hypotension, shock, just change of the temperature? So we have many dilemma when we are dealing with tiny baby. And especially if we have a congenital structural abnormality, we have wide spectrum of anatomical diseases. And if we have spatially venous or arterial pathway abnormality, there is some technical challenge. So upon our guideline, we have program for targeted neonatal echo cardiography in NICU, the different pathology and symptom by previous guideline 2011 and 2024 in PDA in preterm, in acute pulmonary hypertensive crisis, in shock, in congenital diaphragmatic hernia, in pleural effusion, pericardial effusion, and if we have a line in this neonate. But I am pediatric cardiologist, so I will focus on the common indication where we are asked by neonatologists to help, to treat or not to treat a PDA in preterm, to exclude PPHN, and to exclude any structural heart disease in critically ill congenital heart like duct-dependent pulmonary or systemic circulation. We are starting basic echo views, parasternal long axis, short axis, to visualize the left ventricle, right ventricle, and to assess properly the dimension and the function, and sweep from the subcostal view, long axis, sagittal, and suprasternal view is of great value to visualize if we have LVO2 obstruction, the size of the PDA. PDA per se, it could be a problem if we have lone PDA in hemodynamic significant in small baby, but could be a solution in duct-dependent circulation to maintain pulmonary circulation, pulmonary atresia, critical pulmonary stenosis, transposition of blood vessel, and to maintain systemic circulation like in critical aortic stenosis, coarctation, hypoplastic left heart syndrome. We know that the PDA is a large channel in a fetal life and connecting between the main pulmonary artery and descending aorta. And subhanAllah, its media is totally different. It is smooth muscle, contractile, compared to elastic fiber in main pulmonary artery and descending aorta. During fetal life, we have two parallel circulation, and we should have an obligatory shunt, pentaforamen ovale, and PDA to connect. And the right ventricular pressure is 60% of cardiac output. And this PDA is connecting between high pressure of pulmonary artery to the low pressure in descending aorta and placenta. And the prostaglandin released from placenta maintaining the flow through this duct. After delivery and increase of oxygen content, expansion of the lung, combined with increase of bradykinin and decrease of prostaglandin, there is gradual constriction of this PDA. Functional closure occur within the first 2 days of life, and anatomical after 14 to 21 days, where there is a fibrosis and change it into ligamentum arteriosus. What about the PDA in preterm as a clinical evaluation? We have just a murmur or could induce significant seal, hypotension, metabolic acidosis, worsening of ventilation, and insufficient oxygenation, pulmonary hemorrhage, necrotizing enterocolitis. So how we can assess this PDA? And this PDA has different configuration. We know that we have 6 form or shape, the conical, window, tubular type, complex, elongated, or the fetal where we have elongated and tortuous, especially in preterm. What is our rule when we are studying this PDA to confirm its presence or not, to evaluate its size, the shunt direction, the flow pattern, and evaluate if we have a significant shunt through this PDA. Looking to the PDA at the proper site where this PDA and its site, and we evaluate by 2-dimensional, by color Doppler, if it is small, less than 1.5 millimeter, or if it's large, more than 3 millimeter, and we should measure proper perpendicular to the anterior wall of pulmonary end to assess accurately this size. And what else? We are applying continuous wave Doppler. If it is non-restricted left to right flow, we have peak velocity less than 2 meters per second. On the other hand, if we have a restricted left to right flow, it is less than 2 meters per second. With high pulmonary artery pressure, we have bidirectional flow, or even right to left flow with a suprasystemic pulmonary pressure. Then we are assessing the degree of pulmonary overcirculation by the ratio of the left atria to aorta more than 1.5, the dimension of left ventricular and the diastolic dimension, and we are plotting to the D-score. What next? If we have significant left ventricular output where we apply pulsed wave Doppler on 5-chamber view and measure the VTI and calculate the left ventricular output more than 300 ml per kg per minute. So it is one of the markers of pulmonary over circulation. What about the marker of left heart pressure loading with stiff left ventricle? We have high EE ratio by pulsed wave Doppler. By application pulsed wave Doppler, we can measure also the isovolemic relaxation type, and even by TDI, it's accurately measured. The TDI can assess properly the isovolemic relaxation time, isovolemic contraction time, and EE slash. What about the marker of systemic hypotension? By application of pulsed wave Doppler over the descending aorta, celiac trunk, superior mesenteric, and even the middle cerebral artery, we diagnose by reversal diastolic flow over these vessels. So, does echocardiography facilitate determination of hemodynamic significant PDA? Yes, of course. And I want to share with you this publication. As we are pediatricians and neonatologists, we are looking for the clinical finding. If the patient has just mild symptom on minimal ventilatory support, and we are looking for the PDA. If the transductal diameter is less 1.5, if we have a restricted flow, continuous flow more than 2 meters per second without any sign of left ventricular volume overload or pressure overload, so it is a small without any significance. While if this patient high on ventilatory support and mean airway pressure between 9 and 12 millimeter, and there is slight abdominal distension, and by looking for the duct and measuring its diameter between 1.5 and 3, and if we have unrestricted pulsatile flow with peak velocity less than 2 meters per second, and high volume overload with left atria to aorta more than 1.5, and the sign of left heart pressure overload like EA ratio more than 1, so we have a moderate hemodynamic. On the other hand, in a patient with high ventilatory support, even with high frequency ventilation, with marked abdominal distension, we can find ductal diameter more than 3 millimeter, unrestricted pulsatile flow, severe volume overload, mitral regurg, significant pressure overload, and the E ratio more than 1.5, and even the isovolemic relaxation time could be shortened, and reversal of flow across the end diastolic in superior mesenteric artery and descending aorta. So it is of great value to look for the clinical finding and echo parameters. Then we are discussing now persistent pulmonary hypertension of newborn. It is a clinical syndrome with variable severity and degree. It could end in hypoxemia if the pulmonary vascular resistance exceeds the systemic vascular resistance, and we have an obligatory right to left flow across a patent foramen ovale and descending aorta. This is, we know that in cardiopulmonary adaptation, we have expansion of the lung, gradual decline of pulmonary vascular resistance, increase of oxygen level, and increase of vascular endothelial factor, like nitric oxide and prostaglandin and potassium channels. That is why there is gradual decline of pulmonary vascular resistance after delivery. And there is a close link between C-section and PPHN, where there is absence of the physical compression through the birth canal and decreased clearance of lung fluid. That is one of the predisposing factor and coincidence with PPHN to have a cesarean section with PPHN, and the baby is distressed. And we are confronted with many patients like this, this association. And we know that PPHN, it is one of class based on clinical classification of pulmonary hypertension. It's group 1 of pulmonary hypertension, whatever the age. And we have also 5 group or class of pulmonary hypertension. Till now, there is no proper definition of persistent pulmonary hypertension, but there is a consensus. If we measure the pulmonary pressure more than 2/3 of systemic or exceeding, it is pulmonary hypertension. So it's very important to link to the systolic blood pressure to assess the degree and the severity of this syndrome. Due to the effect of pulmonary hypertension, we have definitely shear stress, vascular remodeling, and ending into hypertrophy, fibrosis of right ventricle, and sequentially it leads to right ventricular failure. I would like to share with you one of a very common case in NICU delivered by C-section with meconium aspiration and requiring suction, severe distress, and cyanosis. And despite of 100%, there is no improvement. What next? We should apply pulsed wave Doppler or pulsed oximeter over the upper right hand and lower limb, and we discover that there is difference around 10%. So this patient has hypoxic respiratory failure. We should measure the oxygen index. So to categorize the degree of respiratory failure, then what is next? To assess by arterial blood gas. If we have by hyperoxia test, the partial oxygen is more than 150, so this patient has purely lung disease. On the other hand, if the partial oxygen does not increase more than 100, so we have congenital cyanotic heart disease, while in PPHN, persistent pulmonary hypertension, the partial oxygen is between 100 and 150. And the causes of PPHN, the commonest is a maladaptation where there is acute pulmonary vasoconstriction secondary to pneumonia, to perinatal asphyxia, hypothermia, hypoglycemia, or maladaptation in idiopathic pulmonary hypertension in black lung syndrome where there is abnormal remodeling of pulmonary vascular bed due to the chronic intrauterine stress, or due to the underdevelopment in patient with congenital diaphragmatic hernia where the viscera is inside the lung and there is underdevelopment of the lung tree. And I would like to share this figure. It summarizes the pathophysiology of extrapulmonary, intrapulmonary shunt of PPHN and can lead to left ventricular dysfunction. If you have a perinatal hypoxia, meconium aspiration, sepsis, transient tachypnea of newborn, there is form of ventilation perfusion mismatch and intrapulmonary shunt, and there is high pulmonary artery pressure. On the other hand, if we have idiopathic PPHN, there is pulmonary vasoconstriction remodeling and right to left flow and extrapulmonary shunt through the patent foramen ovale and PDA. As we know, there is interventricular dependence, so the left ventricle is affected by septal deviation and can lead to increased pulmonary venous pressure for this patient. And we should measure properly the pulmonary pressure through the application of pulsed wave and continuous wave through the tricuspid valve and measure the right ventricular to left ventricular ratio to measure the acceleration time and to look for the interventricular septum. As we mentioned, proper application of continuous wave over the tricuspid in apical subcosal view or apical four-chamber view, parasternal modified axis to look for the tricuspid regurg and measure the Bernoulli equation and adding right atrial pressure, which is 5 mm mercury, by looking to the pulmonary valve and degree of pulmonary regurg and assess the mean pulmonary artery pressure. And through application pulsed wave Doppler over the pulmonary artery, we can assess properly the acceleration time, and usually it's very short. What about the right ventricular function? Application of M mode over the interior wall of right ventricle and the movement of from the base to the apex, assessing the TAPSE is our routine work now in NICU to categorize to what extent the right ventricle is affected and to look to the interventricular septum in relation to the left ventricle if it is squeezed or not. And as I mentioned, if we have high and suprasystemic pulmonary artery pressure, the interventricular septum is pushed to the left ventricle and squeezed. If it is in the middle line, so we are expected that the pulmonary artery pressure is equal to systemic. On the other hand, if the left ventricle is maintaining its shape, we are expected that the pulmonary artery pressure is less than half of the systemic pressure. And our goal when we are managing PPHN, it's the improvement of oxygen saturation and proper oxygen delivery to the tissue, optimize lung recruitment, adequate cardiac output and blood pressure, effective pulmonary vasodilator, and reversing right to left shunt. And this is our algorithm. As we mentioned, proper lung recruitment and ventilation, oxygenation, decrease afterload, and proper pulmonary vasodilator. I would like to share two cases very common in our neonatal ICU. If we have a marked hypoxemia and we measure the systolic pulmonary artery pressure, it's around 2/3 of systemic blood pressure, and we are discovering that we have left to right flow across pita and foramen ovale or PDA. So this patient has intrapulmonary shunt, and our rule is optimize the lung recruitment, increase the PEEP, increase the mean airway pressure, and surfactant can help this patient by delivering through intratracheal. But if we have this patient with marked hypoxemia and systolic pulmonary artery pressure more than systemic blood pressure, and we have right to left flow across pita and foramen ovale and PDA, so this patient had extrapulmonary shunt and some affection of the left ventricle diastolic pressure, and inotropic support is very important, either noradrenaline or more than noradrenaline as vasopressin, to adjust pulmonary vasodilator like mirinone and sildenafil. And this our approach to look how to manage this patient with significant PPHN. We have strained right ventricle with dysfunction, pushing the left ventricle, and high afterload. So very important to improve the systolic and diastolic function of the right ventricle by giving mirinone, which is the inodilator, to relieve the afterload by proper oxygenation, as well as pulmonary vasodilator like inhaled nitric oxide. And sometimes we can add prostaglandin to maintain a PDA to like for as a pop-off for this right ventricle to maintain systemic circulation. So to summarize, core echo measurement to look for left ventricular function, right ventricular function by TAPSE and the relation of right ventricular size to left ventricular ratio, the cardiac output by measuring the VTI by the left ventricular outflow tract. If we have a shunt assessment by PDA, ZVSZ, pulmonary pressure, the tricuspid regurg, and acceleration time. If we have an effusion, then upon this is pump failure, left ventricle or right ventricular dysfunction or both. If we have low preload, if we have a small ventricle and IVC is collapsible, if we have a pathological shunt, if we have an afterload with high right ventricular pressure and septal flattening, if we have an obstructive like pericardial effusion and pleural effusion. So upon it, we link echo finding to management. Left ventricular dysfunction could be improved by inotropic support according to our policy, and Mirinon is very fruitful for this patient. Right ventricular dysfunction, PPHN, reduce pulmonary vascular resistance by proper oxygenation, inhale nitric oxide, proper ventilation. And if we have a low preload, careful giving the fluid for 1 or 2 times. And if we have a significant PZA, by medical therapy, surgical, and now we have transcatheter closure. If we have a tamponade, urgent pericardiocentesis, and if we have a structural heart disease, we are calling our cardiothoracic surgeon. To wrap up, understanding the pathophysiology is very important in diagnosis and management in NICU, and echo is a bridge between our clinical evaluation and sophisticated hemodynamic monitoring. And thank you for listening.
Thank you so much for this fantastic presentation, Professor Hala Agha. And I will let Dr. Omar and Dr. Amira to moderate the session with the questions and answer.
Welcome all. Jazakallah khair. Thank you, Dr. Hala. It's a very fantastic, very advanced, very sophisticated, very detailed lecture. MashaAllah. I learned myself a lot also. Let us go in short to the questions in the Q&B. I will start by questions. Me and Dr. Amira, that is directed to Dr. Hala, as Dr. Qasim is busy with the work. There is a first question, Dr. Hala. They ask about what is the normal TAPSE in neonate.
Okay, great. Thank you, Dr. Omar. You know, TAPSE, it is very important to assess longitudinal. Usually, in full term is around 1, but in preterm, it's less than 1. And very important, when we are assessing TAPSE, it is not a single reading. To look for this TAPSE and other criteria rather than TAPSE, like the relation of right ventricle to left ventricle, and the degree of regurg and degree of pulmonary hypertension. And then to look after our adjustment, whatever the pulmonary vasodilator, inotropes, and look what is next for the TAPSE. It is improving rapidly, so we are in proper way. And we are studying previously the TAPSE in preterm is around 0.6, 0.7, but in full term is around 0.9 to 1. And we are measuring, this is very important to apply properly the M mode on the anterior rule. As we mentioned, it is movement. So if we adjust our cursor upon this movement, our reading is appropriate. If the precursor is away from the anterior rule, our reading is not accurate. And its movement is like between the base and apex. So try to adjust your hand and go by the proper slope to find the proper accurate, and repeated many times. And it's applicable also by TDI to evaluate the relation between the systolic and diastolic by S/ and E/.
Thank you, Doctor. Another question here. They are asking about the difference between adult and pediatric images in assessment of echo, and we are more specific. We are just talking about the neonate. It will be more sophisticated if you tell us what is the most important consideration when you are doing echo in the patient in the NICU compared to the pediatric or adult.
Okay, thank you for this a very nice question. You know, adult is not a pediatric, and neonate is not a pediatric. Totally different, and especially within the first 3 days of life, it is not like pediatric at all. The various hemodynamics every hour change our views. And the point when we are tackling with neonate is very important when you are examining to maintain the temperature of this baby, to put in the proper environment, to use a warm gel. So this changes the hemodynamic even when I am examining the baby. If the patient has hypothermia, if the patient is not properly and crying, the hemodynamic changes. So in a tiny baby, in a small baby, it's totally different from pediatric age. The crying during our examination, it is one of the challenge when you are dealing with a pediatric age. And we know that we are not using sedative during our examination till 6 months. We are afraid from the sedative. So we are trying to pacify this patient, whatever our approach. So the environmental factor affect our views to how to maintain the baby in proper position, to view rapidly and to assess properly the views. Concerning the difference between a pediatric and adult, in adult, usually they are not looking for the subcostal and suprasternal view due to the different window. The subcostal view is very limited and suprasternal, but this is our initial and basic views in pediatrics.
Thank you, Dr. Al. And I know if you keep talking about this difference till morning, you will not finish. A lot of information is there, I'm sure.
Yes,
There
Dr.
is
Amar, we have
yes.
other people, maybe 2 or 3 are asking for the tissue Doppler. They're concerned with the tissue Doppler, Dr. Hela, in the small pediatric age group and in the neonates.
Okay.
So,
you know, now the machines, the tissue Doppler, the basic tissue Doppler is available. It's not the speckle tracking, just by application on the apical 4-chamber view and putting the applying TDI over the interventricular septum and over the lateral wall of left ventricle and doing the summation. And if we have the S properly aligned and the proper E and E slash, we can categorize this patient as a poor or normal function. We know that if I am applying the S over the interventricular or lateral wall of left ventricle, the average S is around 0.91. So it is within the range. As well on the interior wall, if we are applying the TDI over the lateral wall, we can categorize if the patient has normal systolic or average systolic function or abnormal systolic function. And then we are looking to E slash. E slash can guide if the A is higher than E, so we are expected diastolic dysfunction, whatever the ratio. But if we have E slash more than A, so we are expected rigid or non-compliant ventricle. This EA ratio in preterm is expected. So in preterm, we have EA slash higher or A slash higher than E due to the diastolic dysfunction, immature ventricle, excessive fluid inside the ventricle. That is why EA slash is inverted in preterm.
Great, Dr. Hela. So great. Dr. Omar, you want to ask some questions?
A lot of questions, mashallah. They like Dr. Hala, mashallah. A lot of questions. Dr. Hala, I don't know if the time is still allow. We can add 1 or 2 questions. They ask only about the reference range. Is it adjustable for the children? You have a reference for that, or it is only by number?
What about the TAPSI?
The
what is
reference range for the TDI.
A TDI. So yes, there is a reference. I can share with them the reference about the S and E slash, but in general, to look for the shape and the adjustment according to the position. And I will share with through this website the reference for the TDI for pediatric and neonate.
Okay. I think Dr. Hala, for them, not to have the real sophistication for our work, when a cardiologist, the real cardiologist is doing the pediatric echocardiography, he can judge with the clinical of the patient, with the ventilation of the patient, with the blood gases of the patient added to the echo. So I think they shouldn't be bothered by the tissue Doppler in neonates or something like this for the time being. They have to look for the patient global, not only just the echo, just global for the whole story of the patient.
Thank you, Dr. Amira. Very nice comment. As you mentioned, we are not a technician. We are pediatrician or neonatologist. And look for the patient. Look to the chest X-ray even. Look to the blood pressure, to the perfusion, and added to the echo. Image can change every now and then, but your decision is based upon your patient. What is this patient? What is the SaO2 of this patient? What is the blood pressure of this patient? What about the chest X-ray? Hemodynamic or not? That is why I shared with you the clinical evaluation published in 2007. It is comprehensive between the clinical status and the echo finding, and not just the echo finding. Echo finding can be many criteria and even changes from time to time. So how to categorize this patient as a small, like the patient who's small or moderate or large? If the patient on minimal ventilatory support and has just murmur, and the size of the PDA is like 1.5, and without any hemodynamic changes, if we are applying the pulse tissue Doppler or TDI, and the isovolemic relaxation is within normal and S is within normal, so this patient has small, non-significant PDA. So we are looking for the patient and echo criteria. As we mentioned, as a hemodynamic PDA, it could be moderate and large based on other criteria: the size, the Doppler, the ratio, the left ventricular volume overload and pressure overload, and TDI. As you mentioned, TDI is not the key of everything in our management in neonatal ICU. It adds, but is not the main finding. We should study our TDI and speckle tracking, but we should look for our patient as clinical finding and hemodynamic.
One question of Dr. Osama, we can't jump over because it looks irritating for him. Dr. Osama, he's asking about some conflict that is daily practice. He says, if we have a hemodynamically significant PDA in a preterm who is less than 32 weeks, who should be the one decided for the medical and interventional management, cardiologist or neonatologist?
Great. Thank you, Dr. Osama, for this very nice and practical issue. I will discuss what is our scenario here in Egypt. Neonatologists ask me, please, I have a murmur and a tiny baby, how to manage. As I mentioned, I look to the hemodynamic, I look to the chest respiratory pattern. This patient is on ventilatory support, skull, and then by echo and chest X-ray. If the patient is hemodynamic significant below 32 weeks, I discussed with them, this is my finding now, and this finding at 1 hour or 2 hours or within the first 3 days of life. So according to the age of the patient, we are deciding what is next. You know, there is a debate about the decision making for the treatment of hemodynamic significant PDA. Previously, they asked that the prophylaxis is the best, but you know, Dr. Osama, it's not any more prophylaxis. We are dealing with a patient with a symptom. And if we have a symptom, and if we have hemodynamic significance, we are starting medical treatment combined by neonatologists and pediatric cardiologists.
I think you
then if medical treatment fail, till now, we haven't the program of transcatheter for preterm. So if failed medical treatment after twice the trial, we are referring for surgery.
Okay, so it's a combined
I think also, Dr. Hala, definitely they should look global for the patient. Sometimes he might have some residual PDA, but his LV is not dilated, his left atrium is not that dilated, and he has chronic lung disease. And at that time, sometimes we shouldn't incriminate everything on the PDA and everything. We have to look for the patient from each system is affected. And also his arterial blood gases, his CO2, his oxygen saturation. So at that time, we can have a real judge whether the PDA is the real significant for keeping the patient on the ventilator, or there is other augmentary lung issues or something like this. Yeah.
Thank you, Dr. Amira. Let's share with you. Recently, I got one of my patients came in. It's now 4 months and came in with pulmonary artery pressure 80, and they're just small muscular VSD. I am astonished why this patient has this pulmonary artery pressure 80 on a small shunt. And when I am discussing with the patient, this patient admitted for 1 month in neonatal ICU on high ventilatory support. This patient has bronchopulmonary dysplasia associated with a small VSD. That is why he had pulmonary hypertension. So history, clinical evaluation is our key, and not just the image to tell what is next for this patient. So the bronchopulmonary dysplasia, one of the sequelae of high ventilatory support, and following discharge, if you are not discussing and discussing with the patient what is previous, we can miss our patient, and assuming this patient has idiopathic pulmonary hypertension. This patient has VSD and bronchopulmonary dysplasia.
There's one question for Dr. Qasmi I can answer on. He's not right now, is with us. It was the really first question just asked in the Q box. Someone is asking about the corrected QT and is telling that it's always missing for her to interpret. My opinion, even for the experts, and this is what I'm doing to myself, no one to look for the ECG and make the opinion without writing the report. Everyone should write the report. So if you write the report, you will not miss anything. If you write everything, then by the end, nothing will be missed. As you were asking about the corrected QT, there is a lot of online applications, but usually if you're just without net or without anything, you can do just simply by the small squares for the QT and the square root of the RR. I think this is the questions only for the ECG. And also I want to announce that this ECG lecture is just an opening for our fellowship. it contained maybe 100 points in the ECG, and our program is going to cover all of these points while we're doing it during the basic diagnostic tools for the pediatric cardiology, and also in the module for the ECG and electrophysiology with arrhythmia.
Thank you so much, Professor Amira, for highlighting this. And of course, this is just an introduction. So we'll have a whole year of education, and there will be emphasis on diagnostics, especially on ECG and echo and cardiac MRI and diagnostic cardiac cath. So stay with us. We will have another webinar next month, and on monthly basis, we'll have 3 webinars, at least for the next 6 months. And we are structuring now a very strong pediatric cardiology fellowship. The door is open to apply. It's again 1 year fellowship, so it needs commitment and time and some dedication. So please, if you are interested, join us. And for the recording, I saw some questions about the recorded webinar. It will be available. We'll share it with you. We have your number and your email address, so we are going to share it with you. And also, you are going to receive your certificate of attendance by next week. With that, we are going to conclude, and I really appreciate the great lecture by Dr. Qasim and by Professor Hala, and the great moderation of Dr. Amira and Dr. Omar Al-Junaid. And we'll see you in our next month webinar.
Yeah, sorry.
Bye.
Thank you, Doctor.
Mhm.
Thank you, Dr. Omar.